Well, good morning, everyone. My name is Dr. Anand Parikh. I'm the Chief Medical Advisor here at the Bipartisan Policy Center, and I want to welcome all of you to today's event entitled Overcoming Healthcare Challenges in Immigrant Communities. I think most of you are pretty familiar with BPC, but we are a nonprofit organization that combines the best ideas from both political parties to promote health, security, and opportunity. Today's event is a collaboration between BPC's health program and immigration program, and I'm pleased to be able to co-moderate today's discussion with BPC's Director of Immigration and Cross-Border Policy, Teresa Cardinal-Brown. Today, our purpose is to raise awareness of barriers to care experienced by immigrant communities, including both non-citizens as well as naturalized immigrants, and to discuss how these barriers can be overcome. We'll explore challenges related to language, to culture, and other factors such as access to health insurance. This last challenge is a particular issue as demonstrated by a recent Kaiser Family Foundation brief, which found that uninsured rates amongst non-elderly adults in this country significantly varied by immigration status. For example, non-elderly adults who are citizens have an uninsured rate of about 10%. Lawfully present immigrants have an uninsured rate of 24%, and undocumented immigrants have a 47% uninsured rate. A similar variation exists for children as well. We're fortunate today to have an excellent panel of speakers who have expertise in immigration policy, in public health practice, as well as healthcare delivery. The format of the event will first include a moderated discussion with the panelists, and then we'll open it up to all of you and have an audience question and answer period. And finally, thanks to everyone who has joined us today via webcast. So at this time, I'd like to turn it over to Teresa, who will briefly introduce our panelists and get us started. Teresa.
Thank you, Anand. So we are fortunate to have a great panel of experts, and I will introduce them in sequence, starting with Duncan Lawrence, PhD. Duncan is Executive Director of the Immigration Policy Lab at Stanford University, so he's joining us from California. The Immigration Policy Lab is meant to build innovative tools and evidence to foster the integration of immigrants. He is a two-time Fulbright recipient and has led research teams and projects in the United States, Europe, and throughout Latin America, and previously worked as a medical interpreter and health advocate in Wyoming directly with immigrant communities. Next to him is Maria Gomez. Maria is founder, president, and CEO of Mary's Center, a community health organization that provides healthcare, social services, and education in the DC metropolitan region. They have a budget of $61 million serving over 50,000 individuals at 8 locations in the District of Columbia and Maryland. She has been the recipient of numerous local and national important recognitions, including the White House 2012 Presidential Citizens Medal. And she has a Bachelor of Science degree in nursing from Georgetown and a master's degree in public health from the University of California at Berkeley. And last but not least, joining us by the virtue of technology and Skype is Dr. Hector Gonzalez. He is the director of the City of Laredo Health Department. He has over 35 years of experience in public health and healthcare, and serves the communities of Laredo and Webb counties in Texas along the U.S.-Mexico border to improve the overall quality of life. So I want to thank our panelists very much for joining us. So to kick things off, I'm going to ask one question. I'll ask each of you to respond in turn. So the title of our event is Overcoming Healthcare Challenges in Immigrant Communities, and Anand mentioned a few of them, but let's start with just describing those challenges from each of your perspectives. So Duncan, from a researcher's perspective, what challenges have you been able to identify in your research that are ongoing with provision of health in immigrant communities?
Absolutely. Thanks for having me here as well. And so I think I tend to come at these issues in my current role from a sort of bird's eye view perspective. I became interested in immigration policy and health policy working as a medical interpreter, which is a very different perspective. And so I kind of want to paint a picture of the current state of migration and then think through a little bit the barriers that, at least at the Immigration Policy Lab, we try to think about addressing. And so we are sort of at this historical moment in terms of immigration. There are 44 million immigrants in the United States. As a percentage of the population, we sort of haven't had this level since about 1910. 25 million of those individuals are non-citizens. Among that population, there are about 12 million lawful permanent residents or green card holders, and then approximately 11 million unauthorized immigrants. And I think one of the key barriers to think about is that immigration status can have a significant effect on your access to care, your ability to access health insurance, and I think we'll be able to talk about that a bit more in detail later. The other component and the sort of other perspective that we take in evaluating, I think, barriers to healthcare and to well-being for immigrants in the United States is we often use sort of two lenses. One is to think about health policy and its direct impact on immigrants themselves. And so an example of that, for instance, is whether or not a state chooses to provide health insurance for undocumented immigrants. So that would sort of be one concrete approach to thinking about things at that level. Another is that we often think about immigration policy itself as creating or facilitating access to health care. And so that is a policy that's directed at immigrants, but doesn't necessarily in and of itself address health. And so an example of that many of you may be familiar with is DACA. And so Deferred Action for Childhood Arrivals is an immigration policy that's designed to temporarily protect people from deportation. That policy may have major ramifications on the mental health of immigrants and immigrant families. And so I think sort of taking into account both those perspectives, that both health policy can shape and determine sort of the set of barriers that immigrants face, as well as immigration policy as a particular element in terms of thinking about the barriers. And those are kind of what I think of as systems level barriers that immigrants may face in terms of accessing care and leading healthy lives.
Thank you. Dr. Gonzalez, let's turn to you. As a public health official, especially one in a border community that serves both immigrants who are resident in your community as well as border crossers, what are some of the biggest challenges you think immigrants face in accessing health care from your perspective?
Good morning to all, and thank you for the invitation. That's a great question on immigrants that live here, in Laredo, Texas, or on the U.S. side, but are not insured is a major problem, barrier, because from the public health side, we want to prevent disease, we want to detect early and intervene early, but if persons don't access care until they're ill or they have a major issue, then we're not doing our job correctly, and many immigrants wait until there's a problem. Some of it is due to not trusting the healthcare system. Some of it is due to not sure how to navigate the system, and then because of their status, they won't ask. And so we see many immigrants then wind up in the emergency room with preventable issues that could have been seen in the outpatient service. Then you have immigrants trying to cross right now, which is a major issue happening right now all along the U.S.-Mexico border, and Laredo in particular. We've been undergoing nearly a month of immigrants trying to cross, mostly children and women from Central America. At yesterday's count, it's 2,000 that have been released in our downtown area at the bus station. And initially, when this started a month ago, it was mainly persons coming from the caravan through Eagle Pass, Texas, and were being processed in either Eagle Pass or Del Rio. And so ICE was calling us that they were going to send a bus to Laredo. Now, today, as of last week, they're being released from everywhere, from the port, from ICE, from CBP. And so these persons right now are coming in not knowing Laredo, not knowing the U.S., being afraid. And I'm concerned about their health issue because fortunately, for the most part, we're talking about dehydration, we're talking about minor colds and coughs, but what happens when they leave from here? How do we assure that they're protected? Because they're here. They're here. We want them safe. We want our community safe. So how do we, from a public health perspective, assure that these persons are provided the preventive care services that they need? So both persons who live here already and don't access care because of an uninsured or legal status is a concern. Now, the health department and public health in our area serves as that safety net. So ours is, it doesn't matter what your immigration status is, we're going to provide care for you. We have to. Certainly some programs, especially in Texas, do require citizenship, and so that's another barrier put from the different services. But fortunately, most of our services in public health can provide preventive care services, such as immunizations, prenatal care, regardless of your immigration status. But we can't deny that your immigration status, being uninsured, or a recent immigrant, does impact that you access care. And for us in public health, the earlier we see you, the better we can prevent serious health issues.
Thank you. Ms. Gomez, as a clinician, you see it daily in your clinics, the immigrants who come to receive these services. What do you see as the challenge?
So let me just say, I work for what is called a community health center. Some of you may know it as a federally qualified health center. So we are the safety net for this population. And so let me just paint a scenario that I think Dr. Gonzalez just talked about, that is real life when, people are migrating now here, and they've been migrating. We established Mary Center 30 years ago. 30 years ago, we established it because of the same thing. If you remember 30 years in the 80s, it was the same exact thing. I see a teenager who fled his country because both of his parents and unborn brother were killed back home right in front of him. He has two other brothers that he has to come to the States and work to support those two children, siblings that he has at home. Those are the dire circumstances that people are coming here with. That's minor, but this is a teenager who has witnessed the killing of both of his parents and now has to come here, is required because he's so young to enroll in school but also work. A gentleman who is here in this area, in this region, who worked for 30 years for an organization, got laid off without any benefits. And he was the sole source of his wife, who had really severe diabetes. And so now they have no insurance. The opioid crisis that is happening in this city. People coming from all over the city to our center to seek refuge, to make sure that they can get back their family, get back their home, get back to enjoy life. A gentleman who had a heart problem, who didn't have insurance, but we were able to get him a pro bono surgeon to do the surgery for him. But he had to make a choice, and he made a choice to postpone the surgery, even though he was going to get it, because he could not afford, and he was threatened that if he took off of work, he would lose his job. So his job at that moment in time, was more important than him having his heart surgery. The parents of a child with disabilities. We all know somebody, or we all maybe in this room have children with disabilities. We know how much it takes to take care of that child. And that parent who doesn't have the security of taking off for this child's appointments now has to choose to either give care to that child or lose their job. So those are the kinds of things that we're seeing at the center, and I can go on about the circumstances of their health insurance and all that, but we cover the language, the cultural piece. But I think that, as Dr. Gonzalez was saying, how do we get people in early? And I think for us, if I give you the example, if you look at the teenager who came to this country to seek just to survive and to feed his siblings back home. That individual, for instance, the last thing he needs is for us to provide his vaccinations, to provide, an annual checkup, to get his dental care taken care of. He doesn't need any of that. He needs right now for us to find him a job, to tell the school how he can arrange the school process so that he can graduate from school, learn English, and continue moving up that economic ladder while working and supporting his two siblings. And yet he's 16 years old. So all those social determinants of health that you hear about nowadays are so crucial to getting people into primary care and just keeping them in primary care.
Mm-hmm. I think what we're hearing is that the nexus between immigration and health occurs at multiple levels. Right? There's the level of public policy, there's public health, and then at the front line in the clinical setting for healthcare. And maybe Duncan will start maybe at the top from a policy perspective, and you started to allude to this, but immigrants accessing affordable, accessible health insurance, states have a pretty powerful, important role and an opportunity to facilitate that access to health insurance. And your immigration policy lab has done work with states like Oregon in terms of prenatal expansion of care. Talk a little bit about your research and the role that states have to facilitate access to health insurance for both, I would say, lawfully present immigrants as well as non-citizens.
Yeah, so I think states have important health policy levers when it comes to thinking about public health insurance for immigrants, whether they be green card holders or undocumented immigrants. And so as a result of sort of reforms, welfare reform in 1996, something came into place called the 5-year ban, which meant that immigrants that came to the United States and had only had their green card for less than 5 years, states actually couldn't extend at that time Medicaid coverage to those individuals. And so you could be a green card holder, but you wouldn't have access to care. Also, undocumented immigrants generally can't access Medicaid services. However, states do have some options now as of 2009 to extend coverage, for instance, to undocumented immigrant mothers in terms of prenatal care. And so at last count, I think only 33 states had extended this type of coverage. But that, for instance, allows undocumented immigrant mothers to access full scope prenatal coverage via Medicaid. And so my research team sort of wanted to answer this question about what actually happens for health outcomes for both mothers and infants when you extend prenatal care to the undocumented population. And with the support from Robert Wood Johnson Foundation's Evidence for Action program, we were actually able to do an evaluation of an expansion program that occurred in Oregon between 2008 and 2013. And so the state decided that they were going to extend coverage to undocumented immigrant women, but they staggered the rollout of that coverage. And so that program sort of moved county by county, and we were able to use that staggered rollout to understand the effect of that coverage. And the results were, frankly, I think, pretty astounding in terms of positive health outcomes and utilization for both mothers and their infants. And so we found a significant reduction in infant mortality, a significant reduction in extremely low birth weight, and we also found that infants were more likely to get their vaccines. And so I think if we think about these policies not just in terms of how sort of health policy affects the immigrant family unit, but for instance when it comes to vaccines, there are also sort of cascading effects that can happen across the community in terms of how we treat immigrant populations from sort of a policy perspective.
Mm-hmm. Dr. Gonzalez, let me ask you, in your role for the City of Laredo Public Health, you have partners at the federal, state, and local level. You mentioned in your opening remarks some of the restrictions that the state of Texas has on some of the services you can provide. Dr. Lawrence mentioned some of the federal restrictions on Medicaid availability for certain immigrants. What has the City of Laredo done, and how do you sort of navigate through those different strictures on what you can provide and to whom?
I think the word you use, navigate, is excellent, because that's what we have to do. If one program doesn't allow, then we use another program. Lawrence just mentioned the postpartum extension under emergency Medicaid. Texas has it limited for 30 days. We're trying to increase it because we know that mom's health impacts the entire family. And talking about social determinants that Maria mentioned very well, that's also another issue that prevents immigrants, both legal and those with questionable status, to access care. And we know that moms need to come in and to care during prenatal care, need to stay in care after and in between pregnancies. And one other cultural issue is that women wait till the end. First is the kids and the partner, then women, and more so in immigrant families. And so a big push to try to get women to understand the importance of they coming in first, because if they get sick, then who's going to take care of everyone else? Then you have the issue of the different programs, as you were, the eligibility. So what the city has done here in public health in general is making sure that everyone has those preventive care services, prenatal care, family planning, immunizations. And to us here in Laredo, it doesn't matter what your legal status is. If no one else can see you, we're going to see you. And this has a double component because we have such a large uninsured population that we have to. And then we're also medically underserved. So many of our physicians who do excellent care just don't have the opportunity to see someone. And so we wind up seeing them through public health. And we don't only serve our immediate community, but we serve 11 other smaller rural communities that we're the medical hub. And so policy decisions about who can access care are very important to us, but Laredo and public health in our city and in general, that has to navigate that to make sure that we provide those preventive care services. There's some women, for example, who come to us and have never had a mammogram. And so these basic public health preventive care measures have to be available to everyone, because then we're going to face the obvious at the other end is catastrophic disease, emergency room disease, hospitalizations that increase the healthcare costs all over. And so ours is, again, we want to prevent, we want to detect early, but certainly the policies of the different healthcare programs do impact us. But at the local level, we have to take the charge and the lead in providing care for everyone, regardless of your legal status. Mm-hmm.
I want to ask Maria about clinical community linkages at the front line, but Dr. Gonzalez, if I could just follow up. So the city health services that are provided at the health department, so the dental, the clinical, TB, WIC, immunizations, just to clarify, are those services at the city health department, or city health services, are they, is everyone eligible to receive those, or by program, it depends?
Other than WIC, all the programs are available, and it is a partnership, because funding for us comes from CDC, from the Centers for Disease Control, to the state of Texas, to the Texas Department of State Health Services, then to us, and then locally, we provide local resources as well. But the WIC program does require proof of residence, and that's fine. And so for us, they give us an address, they live, they work here, but it doesn't go as far as asking legal status. There is one state program that does. And so we navigate that state program that is actually for women and their family. When the question of their immigration status comes up and they don't qualify under that program for the preventive care services, for their checkups, then we use another program, and we have to, because we need to assure those preventive health care services.
So, Maria, I guess a lot of questions here. This is sort of a choose your own adventure here, but I know on the policy-related issues, You have sites of care in D.C. as well as Maryland, and there are probably some differences between D.C. and Maryland and what you can do, and you may want to follow up on that issue. But on the issue of sort of clinical community linkages, one of the things that makes Mary Center a federally qualified health center produce the health outcomes that you're able to do. You have a clinical emphasis, and I'm curious on how you navigate the cultural language barriers, but on the community side, your ability in a holistic way to link patients to those services that they need related to the social determinants of health, I think make you all unique. So if you want to touch on any of those, I know there are quite a few questions there.
Just really quick, I think I just want to follow up. I think as an example, I think not because I'm a district resident, but the District of Columbia has had just an amazing excuse me, coverage, where 98% of the population is covered, including the undocumented, and they do that undocumented coverage through city dollars, city appropriated dollars, that it covers both the primary care, specialty care, and hospitalization. And it hasn't had an impact on the budget, really. We've had some issues around, people coming from other areas, Hagerstown, Frederick, all over Virginia, to come and try to get the services here. So that trying to limit that access, I think, has been something that the city has struggled with. But definitely that access to the undocumented population has really, really helped on the outcomes, both on the prenatal side, but also on the adult side, where we see that, for instance, at Mary Center, we just did an evaluation with NIH and Urban Institute that showed that the services, the linking of services, not just to medical, but to all the social determinants. We have over 100 organizations that we work with. And that web of partnership is all to itself like an arm of, hundreds of thousands of dollars that costs us to do, but worth every bit of it. And that we know, and we saw through the report, that on the adult side particularly, that when the adults and their families seek those services in addition to the medical care, the more that they're touched by those services, the better they fare on diabetes and hypertension and high cholesterol. It's so evident. I mean, it shows so clearly for the people that have those diseases, those health problems, that the more they're touched by those social services, the better that they fare. That's an outstanding, that's something to say about what we should be doing, a practice that we should be doing for everyone, not just the undocumented. I think that on the, I think I touched on pretty much all of them, but I think I would just say that the evaluation that we did was very evident also on the idea that it takes that organization, it takes maybe the government, whoever the provider is, to actually be a leader and be an advocate, and to really take the pulse of the community and have programs that really are addressing not necessarily just the medical, but that if you address all these other issues, you may never have to address the medical side, because you're doing the prevention side so early. Yeah.
So from the public policy angle, Duncan, I want to ask you, states that have chosen to expand care to various immigrant populations, it can be controversial at a state level. It's certainly controversial at a national level. What are some of the things that you think have contributed to allowing those states to do that? We talk a lot about the outcomes for the immigrants themselves. Is there a cost savings to the state? Is there a general health benefit for the overall population, regardless of status? What have you seen have been some of those things that can help states sort of overcome maybe what might be political obstacles to doing that?
Yeah, so I think there's a couple of things. One is in what we've seen, there's always the fiscal projection about cost, and then there is very little follow-up on sort of what the actual program itself costs. And so one of the things we've been working on in Oregon, sort of a follow-up to the work that we've done, is actually putting together a cost analysis of the implementation of the expansion of prenatal care. And so that hasn't been published yet, but it's a working paper. And we find that in general, it's cost effective based on the savings that you get from the returns of that policy in terms of the health outcomes. And so if you compare sort of utilization and a reduction in some of the things that I mentioned, it ends up being a cost-effective policy. I think in the states where you also have seen expansion, there is sort of a degree of a normative component about wanting to make sure that the general population has access to preventative health care services. And so that requires political momentum, as you mentioned. But I think for states, and at least in sort of the rhetoric that I've seen in California in particular, for instance, about expanding healthcare to all undocumented children just recently, and currently the new governor at least has the idea to expand Medi-Cal coverage basically to all undocumented immigrants under the age of 26. There is, I think, an argument about the longer-term impact that those policies can have, which is really tough to get grounding on in terms of cost, and then also an argument about equity, which is that they're, from a state's perspective, these are residents of a particular state, and there's no reason that they should be ineligible for a set of preventative health care services simply because of their immigration status.
Can I just add, I think, well, prenatal care is really, and we started, so our name is Mary Center for Maternal and Child Care, so we started with prenatal care, but it is, obviously, there's been enough research, and I think that one preventive care that we should really all commit to provide, every state should do this, is family planning, right? So we know that if families can plan when they want to have children, how many children they want to have, that really sets them for, it's a trampoline to a better financial success and a better life. And so I think that I would say that that's, in addition to prenatal care, that we have so many people that, oops, I'm pregnant today. I really didn't want to be, but I think that we see when we prevent teenage pregnancy, when we prevent parents that are already over stressed to have another child that is an unwanted child, it deals with the whole child welfare system, right? So the number of children that are not abused because they're not even born, that has an implication. The number of children that are not abused and the effects that has on learning and maybe the justice system in the future. So I think that it has so many repercussions in terms of preventive services that we see every day. Yeah.
Dr. Gonzalez, I want to extend this conversation on the impact of immigration policy on kids and children's health. And you mentioned that from a cross-border perspective, that a lot of the individuals coming across the border are children. If you think about issues related to physical health, mental health, vaccines, from your perspective, what is the impact of immigration policies on the health of children? And I'll start you off maybe with two more data points from the recent Kaiser Family Foundation brief. 1/4 of children in this country have an immigrant parent, and 10 million children, citizen children in this country, have a non-citizen parent, and therefore are likely to be more uninsured. So talk a little bit more from your perspective about the nexus between immigration policy and the health of children.
I think both Lawrence and Duncan and Maria brought up good points. At the end, the bigger question is if we don't provide care for children, prenatal care access for women, then at the end we're going to face catastrophic healthcare issues. So we've got to provide preventive care services. We've got to provide access, and that's for everyone, not just immigrants. And so the policies that are right now developing and being discussed on immigration does impact, especially in particular children, because because parents are concerned because of their status, won't bring the U.S.-born child to services. And that's an impediment. So a lot of outreach, a lot of education, and going out through different channels. We have a program where, a while ago you asked me about, if they don't qualify into one, we navigate them through it. We even have a partnership with the Mexican consulate with Mexico to provide services for persons wherever. We confirmed a cancer in a child, uninsured, parents aren't legal right now. So what did we do? We got them care in Nuevo Laredo, in developing relationships with our counterparts from Mexico. Wherever we have to go, especially when it's a child, we know that if children aren't fed well, aren't healthy, they're not going to learn well. And especially when you're looking at new immigrants. So we've got to provide that venue for them to come in and access care. The WIC program is a wonderful program besides what it does in providing supplemental food and nutrition education, is that it links them to healthcare services. And that's a concern for me. Is mom being seen during pregnancy by a physician? Is baby getting all their immunizations and their well baby checkups, their dental checkups? Those we have to maximize those programs and services when they walk in the door to make sure that we address all the issues. So health care is a priority, because for many, especially immigrants and new immigrants, health is the least of their concerns. It's jobs, it's home, it's the rest of the family. And again, I look to that women take the leadership role, and so we want to make sure that women and children are provided care. But children, more in particular right now, is because of everything that Maria said, of the different social determinants that impact them, critically that we get them into healthcare and detect issues that impact their social growth and development as well, not just their physical health. I mean, kids right now are facing a lot of social influences that, if we don't have them in care and do a well child, but an extended well child exam that does cover behavioral health, that does cover growth and development, that does cover other services like oral health. I mean, in our case, many immigrants have never seen a dentist. And so ours is, we have to provide them, and we have a wonderful partnership with the dental school out of San Antonio, where the dental residents come and provide care. So again, we have to look for venues to make sure, and partnerships, that whatever we need to do, we provide those services. I'm very concerned about what's happening in the country right now with immunizations. I mean, here we have a core public health basic tool that provides preventive services against very serious diseases that many of us don't see because of vaccines, yet we're facing, not just in the U.S., but worldwide, a population that's unvaccinated. And in Texas, we've got an outbreak of measles. And some are immigrants that go back and forth to the different countries and then come back, but don't come to care because they're uninsured and their legal status. So ours is, it doesn't matter what your legal status is. We need to provide services early, so come in, especially children.
Can I just make a statement?
Absolutely.
Just want to make sure people don't leave. I think that it's really important also to know that the whole immunization, lack of immunization is I don't want us to leave with the understanding that it's done, immigrants are most, I think right now is the most highly educated individuals in our country that are not getting their children immunized. And that's something that should worry all of us as we are in transportation together and our children together and we, eat together and we, so I think that that's something that he just mentioned very serious throughout this country for everyone.
Duncan, you mentioned earlier on the legal prohibition on green card holders accessing Medicaid for the first 5 years they have a green card. That was passed back in 1996. I want to talk really briefly. This administration has proposed a new regulation that would expand how they determine something called public charge, which is a ground of ineligibility for immigration. And some of the things that they are trying to expand the consideration of who might be seen as a public charge and therefore ineligible for immigration may include certain health benefits. What have you seen are some of the issues surrounding that? How are immigrant communities reacting to even the proposal that we're seeing going on?
Yeah, so I think the response has been, at least sort of in the immigration advocacy community, a huge amount of concern, and I think in the immigrant population, quite a bit of confusion. And so, as you described, the sort of list of things, services that you might access that would now create sort of this notion of public charge, the proposal is to expand that list dramatically. And no longer do you have to significantly rely on those services. It would just be the use of them that would structure things in terms of deeming someone a public charge. So the reality is that would really restrict people who are then going to apply for a green card. I think what's happened, we do a lot of work around naturalization. And so accessing that set of services and then applying for naturalization after you have a green card, at least under the current proposal, would not be affected. However, a large number of the service providers that we work with have started to get a series of questions around, I don't want to access public benefits because I'm concerned about my naturalization application, which shouldn't be affected by this. The other is what we've been talking about in terms of families with sort of mixed status. So you might have someone who already has their green card, who has a family member, whether that's a spouse or a child or a parent, who is going to apply for a green card. And there's also a large concern that anyone in that family accessing that set of benefits is going to put at risk that individual's ability to apply for a green card. And so I think anecdotally what I have heard, and you may be able to comment on this more specifically, is that you've seen people non-renewing. And so the feedback we've gotten from service providers that we work with in New York is that people have stopped actually renewing their benefits because of that concern. And I think broadly speaking, I don't think there's been a good sense sort of nationally of whether that sort of anecdotal pattern holds, but you may be able to comment on sort of what's happening here in DC.
But if you see
exactly the same thing. I mean, we're seeing people getting off of programs like WIC, which should not be a program that affects them. So not to be repetitious exactly, all over. And people calling us from people who have been with us and now are living in another state, asking us, we received services from you, we got this and the other, is that going to affect them because my family is now going through the process of getting legalized. I think that I just want to add another piece that is really worrying our community, both on the service provider piece, but also on the community level, as they begin to understand what the census is about, is this whole citizenship question on the census. And that is really going to affect not only, well, it's going to affect the way that resources are going to be distributed to areas. And so if all of our individuals that already don't come out and fill out the census now, no one comes out to fill out the census, and no one opens that door to allow someone to come in. The resources to places, to cities, to states that really need that money is going to be really harmed. So.
Maybe one final question, and then we should open it up to audience Q&A. And and maybe this is for all of you, and Dr. Gonzalez, we can also prompt you, but I think irrespective of where Americans may be on the immigration debate, irrespective of party affiliation, it seems to me this issue of immigrant health is more than just a niche issue. It, in fact, impacts all Americans. I mean, we heard about the issue related to communicable disease. Communicable diseases don't check your citizenship, for example, or your immigration status. You all touched also on the fact that most immigrants work or are in families where individuals work, and poor health of immigrants impact worker productivity, impact business, impact our economy. If you look at our healthcare setting, a lack of access to care and health insurance leads to uncompensated care for our healthcare system as well. So it just seems like this is more than a niche issue, irrespective of where people may be politically. These are challenges that are impacting the immigrant population, but ultimately impact all Americans. And I'm wondering whether you believe that that's the case, and whether there are key points there that you wanted to make.
Do you want me to? Or Dr. Gonzalez?
Dr. Gonzalez, why don't you go ahead and start us off on that one?
Well, and thank you for allowing me to cut in, because that's what we see every day on the border. We have people crossing every day to come work, come shop from around our city and county on the U.S. side, but also from Mexico every day. And then you have migrants who are migrating from all over the world. I mean, this week in one of our shelters, we have persons from Central America, every country from Central America, from Cuba, from the Congo, and from Syria. And these are folks that cross every day through the port of entry and claim asylum or other ways to come in. But we see that every day. That's an everyday. And if we don't provide access to care and help them understand the importance of coming to preventive care, wherever they wind up going, they're living here, they're working here, they're providing here. They deserve healthcare access, because we know that a healthy community, a healthy person is more productive than an unhealthy. And then we've got to make sure that they understand how to navigate the healthcare system. And for immigrants, it's very difficult, because it's a totally different system, and they're not used to it. And so the outreach that we do to them to understand that they can come in, that they can access care, is critical. But here in Laredo, as I said, we live it every day, so it doesn't matter from where you're at. If you're here and you're sick, we're going to see you. If you're here and you need a checkup, we're going to see you. Mine is the whole family, children, women in particular, because for all of these issues that were discussed earlier, from your green card status to here on the border, the wall caused lots of folks not to access. And we talked about WIC. We saw a big dip in WIC because of all of the immigration discussion. And so what we did is we decided to go out into the neighborhoods to talk to folks one-on-one with what we call promotoras, promoters of health that are their neighbors, and they have trust in them to tell them, no, you can. This is a service you qualify. You may not, but your children. So your children can come in. If you're pregnant, then under the state policy, you qualify for emergency support under the different programs, and then for 30 days after postpartum. We're trying to extend that, but at least people don't know that, and people are afraid. And then there's a little bit of stigma as well on the whole issue of immigration. So again, that's something that we face here every day, with people coming in back and forth. Laredo is the #1 inland port of entry into the United States, with 40% of all inland trade coming through here. And so we have persons from all over, and we need to make sure that immigrants in particular are comfortable to access care wherever they may wind up, and that's why I think public health's message has always been to prevent, to come in, to get your checkups, and I really enjoy the comments from both the other panelists, but Maria bringing up the social determinants, and that's for everyone. We really need to look at comprehensive health care, integrating nutrition, integrating behavioral health, integrating disease self-management to understand what we're facing. Because if we improve our healthier outcomes, then we're a better community. And public health, that's part of our charge.
Thank you, Dr. Gonzalez. Do you want to make any more comments?
Sure. I'll just briefly say I think the answer to your question is yes, absolutely. So I think immigration policy as a whole has a dramatic effect on communities more broadly, well beyond the immigrant population. And so if we sort of think of health in a very broad, holistic sense, everything from providing undocumented immigrants with driver's licenses may have a set of particular ramifications for individual immigrants who are now able to drive without the fear of having their car impounded or being detained because they don't have a license. But that also is a perfect example of an immigration policy that now creates, at least from the work that we've done, safer roads for all drivers. And so I think the lab that I run, we do a lot of comparative work all around the globe. And what we regularly find is that communities that invest in inclusive immigration policies often see returns back to the community. And so that could be a country that's providing access to the labor market early on for asylum seekers, for instance. They see an increase in employment rates, and I think those types of things have a general return that can benefit the community overall.
Mm-hmm. I just would say that I'm a great example. I came from Colombia, war-torn country. I was raised very poor over there, with no vision of ever getting an education over there. Came here. It was much easier to immigrate here back then. I'm old, and but I think that I just taking that experience helped me create Mary Center. When I saw in the 80s, after being highly educated, coming back from Berkeley with a master's and seeing what was there, I was either going to go and work and make millions or start Mary Center. So I think, when you as an immigrant feel the love, if I can just say that, and the opportunities, don't have to be given to you all the time. You will seek those opportunities and you will grow. And so I would just say the opposite of that, we see that with, in this country with anyone, not necessarily minorities. Isolation and racism and keeping people out of the network, out of the whole country's sort of prosperity, will have repercussions in terms of people joining the gangs, and in terms of people dropping out of school and becoming more of a nuisance to society than a success and giving back to community.
Mm-hmm. Thank you. All right, so we're going to open it up for questions from the audience. We'd like you to raise your hand. We have some people with microphones, so if you could wait to start your question until one of the microphones gets to you. We also request please ask a question, not give a speech. If you wish, you could identify where you're from and what brought you here. So are there questions? This gentleman here.
Thank you. I'm an attorney. I'm interested in immigration issues and do some pro bono work. But I want to ask the panel to comment on behavioral health, because I'm aware of the work on ACEs done by Margaret Burke-White and others. I heard Maria mention that, and Dr. Gonzalez as well. But I wonder whether behavioral health services are available in the same way. And I also wonder whether the panel would share my view that they're critical to things like diabetes and other health conditions.
I would just say, absolutely, we need more funding for behavioral health. But I can tell you that we took our behavioral health program out of the four walls of the center and took them into 20 schools. And it has just it allows children to stay in school not have to come for their behavioral health services to the center. But two, what it does is behavioral health is also supporting administrators and their teachers to make sure that they understand the kids. Still we have so many teachers that don't understand the plight of immigrant kids and what that means, the plight of their immigrant parents and why parents don't show up and become civic participants in their children's education. So yes, behavioral health, mental health is just crucial, but we got to take those. Two things. We either integrate it into the physical health services that is seamless, so that people don't know that they have to go to a different building, or we go out of those four walls and take it where people are, in the schools, in the churches, in the houses of prayers, wherever people are that they need the services. So absolutely.
Any other panelists?
If I can add to what Maria said, and absolutely, that's why in our health department, we've integrated behavioral health for 3 years into primary care services. If you come in for a sore throat, you're going to get a behavioral health screen. Now, when you're talking about migrants in particular and children, in the 2012 surge here in Laredo, I personally was there checking unaccompanied minors. Can you imagine the threshold, the potential behavioral health ramifications of a 1-year-old that was left in our port of entry in 2012? And most of them were 10, 11, 12, 13 by themselves. Absolutely, behavioral health has to be a component of preventive and primary care for everyone, but in particular for migrants. And today's surge of migrants is families, mostly women and kids. 50% of the 2,000 that we've seen in a month are kids, are children. And so mine is their healthy growth and development absolutely needs behavioral health services as well.
Thank you. Other questions from the audience? Someone up here?
Hi, my name is Caroline. I come all the way from Boston, and I always try to come in here on time, but for some reason or another, it's either the raining, it's either the taxis, or it's either something. I've been a licensed medical social worker for 30 years of my life, and one thing I cannot understand is why they have to have such a horrible and awful lots. I have many years to see children who have born in this country translating to the parents very sensitive issues that only adults talk. And I feel very bad about the whole situation. I have a little comment to say. I don't know if it's the right thing to say, but I want to say it anyway. I think we need a woman up there in Washington, in the House. We need a president, a woman, because at this point, men have done such a lousy job with everything. So we need to have a lot of change. We need to have a lot of new laws. We need to have a lot of support from everyone. I come in from another country also. I have Spanish, I have French. I speak both languages. And always my feeling is, why this great country with all the education and everything else, the people, everyone, or most of us are immigrants. Why we have to go through such a painful situation? Should it be better way in the United States to take care of immigrants, or to take care of the law, and beginning from inside, not from the immigrants, because sometimes the inside is very bad too.
Thank you.
So I do really appreciate it, you guys, for inviting me here. I took my bus, I come here, and I will come in next week and the week after.
Thank you.
I do really appreciate the fact that you are here, that you are able just to teach all these beautiful people about these particular issues. They are very sensitive for every one of us.
Thank you. Thank you very much. Maria, I'm going to ask you, because you probably see this daily, kids who have to translate for their parents complex medical issues that are very sensitive.
Right. Right. There is a law that's not supposed to happen, and so anyone who is actually allowing that to happen is, there's a law. The $8 million that we spend on free care, part of that is translation. There's a law that we have to either have a phone or you have to have a person or you figure out some other way, pull somebody from your work somewhere else that is a professional, not somebody in facilities that can translate. But that is against the law, and I think it's very dangerous, and no physician should put themselves, or practitioner of any type, should put themselves in that precarious situation. Yeah.
So what's the challenge? I mean, you talk about telephonic translation. Dr. Gonzalez, you mentioned that in your community, you might think that the prevalence is Spanish, but I'm sure with many of the Central Americans, there are other languages, and now you have people from the Congo and other parts of the world. How do you deal with the language issues when you're trying to serve these communities?
Great question, and the whole issue of children translating, I agree with Maria, it's not legal anymore, but it doesn't mean it doesn't happen, and it used to happen a lot before. Can you imagine putting the child in that situation of translating the health issue for the parent? So I'm glad it's not a practice anymore, but we still have, in dealing with persons from other countries, we're using any way we, immigrants are resilient. The folks from the Congo learned Spanish, or we spoke French to them. We find the medium. There's also a software app on your cell phone that accepts the language that you're speaking and translates it to the language you ask it to. So to many of them, we were speaking that way. Fortunately, our community has predominates English and Spanish, but we because we are international, we have lots of professionals through our universities that can speak different Asian dialects, that can speak French, that can speak other languages. But one of the things we found recently, especially with speaking to folks from the Congo, it was using an app that translates. Now, migrants from Central America, most of them do know Spanish, so we've been able, but a few are native Central Americans that don't even speak Spanish, so that's a whole another issue. And there's where we're going to have to be ready to develop that communication system with them, because again, talking to them and developing a trust with immigrants and with everyone in general, it allows them to come in and access care. So for healthcare, that communication is important.
Mm-hmm. Mm-hmm. I would just add to that, I think one of the trends we've seen in terms of immigration patterns links into this need for sort of improving linguistic access. And so between 2000 and 2010, about 55% of all new immigrant arrivals were from Latin America. In the last decade, that's dropped to below 40%. And Asian origin countries have filled in that gap. So that now makes up 41% of new arrivals. And immigrants are not just going to traditional receiving communities anymore. We've seen big surges in immigrant populations in places like North Dakota and West Virginia, just down the road. And so those communities, I think, are also going to have to address one of these key barriers to access, which is language. Mm-hmm. I think, fortunately, there are new tools that are continually being developed that try to get as close to what, from my perspective, is the ideal, which is having a fully bilingual provider. That's not always something that you can do. Yeah. And so whether it's in-person, telephonic, or video interpretation, I think there is improvement on those technologies.
Yeah, the technology, we're getting closer to universal translator, but yes, not quite there yet.
I would just add, go ahead, you can ask a question while I get to you. I would just say, we need to also work down the chain and just working with universities. I think all of our children and grandchildren, and should be able to learn a second and third language. So that everybody is able to work with the population, and also just getting that pipeline of minority kids who speak those different languages into the schools of profession. So
well, I might just add that the reverse is true too. The access of immigrants to English language learning is an important component of that. I mean, we can do what we can to try to access them in their language, and particularly for important health issues, you want to be able to access them in the language that they are most able to understand and comprehend. But the issue of trying to help them, and you said you do reach out in community services, help people get to English language learning, which can help them in their economic outcomes and things.
We have a school for dual language. The school that's part of the health center is the parents and the children learning together. The parents learn English, learning skills, they're learning, getting a GED, while learning about how to develop your child and how to raise a child in America.
Yeah, that's great.
Sorry.
Hi there, my name is Yusra. I'm a reporter at Morning Consult. Thank you so much for hosting this panel. I was curious about whether there are any examples of some states or cities that are doing particularly meaningful work on sort of expanding access to preventative care and reducing that overutilization of the ER that could be replicated maybe in other states or perhaps even at the federal level.
Duncan, you probably may have some
Sure.
of those.
So I can at least comment on a few examples. So I think DC is a great example that you can use to leverage. If you look at sort of states that provide, or DC in its capacity is often being tagged as all 50 states plus the District of Columbia, providing access to care for undocumented immigrant adults, for instance. That's a great example. New York City right now is proposing a program that would expand on a program that they've had that provided sort of limited preventative care coverage that would basically provide full scope health insurance to the undocumented population in New York City. There is a proposal in California to expand coverage not to all adults, but anyone under the age of 26 who's undocumented. And so those are some examples of expansion of care. There are currently only 6 states that provide coverage for undocumented immigrant children in terms of full scope public health insurance, and I believe Oregon was the most recent to adopt a new program for kids.
Dr. Gonzalez, you wanted to weigh in on that?
Yes, what we've done in particular, two efforts that we've done. Texas did not expand Medicaid, but what they did was develop a waiver transformational preventive project that we've been doing for 6 years now. All of it incorporated partners like our mental health authority, public health, and our hospitals. Because at the end, what we wanted to do was make sure people access care and didn't go to the ER to use as their primary care provider. So all of the projects that we've done, from extending services, from using non-traditional methods to go out into the community to link persons to care, we've been testing and happily to report that we've had good success in getting the message out of be active, eat better, and see your provider. And if you don't have a provider, we've got this group. A second project that we've done over the last 4 years is another partnership with the FQHC, the Federally Qualified Health Center, again, the Mental Health Authority, our university, and Methodist Healthcare Ministry. We partnered together with public health in the city to do outreach healthcare teams and to use Maria's terms, go outside of the 4 walls, going out into communities and building those linkages, but also in providing those primary care services was integrating behavioral health and entitlement. And so if persons qualified, we had a caseworker, and the person's qualified for any of the entitlements or not, is show them that you can come to this network of providers to avoid going to the emergency room. In our case, it's even more critical because we don't have a hospital district, and so our 3 hospitals that we have for our population of 264,000 is always overwhelmed. So we don't want persons to go to the hospital unless it's really an urgent issue or an issue that needs hospitalization. And so these two projects that I mentioned have really shown good efforts in getting people into the healthcare network, but a lot in having them understand the importance and being able to access regardless of your immigration status.
Thank you.
We've been very successful also with telemedicine. So telemedicine has been great to get into the home for immigrants, but also shut-ins, and just trying to assess to see if the person actually needs medical care, behavioral health care, or do they need to deal with the social determinants of health. And so it's been a really, really cost-effective way to expand health care.
Do we have any more questions?
Can I just add to what Maria said? Absolutely. We are a health professions shortage area, so especially in some areas, psychiatrists, we don't have a private psychiatrist, and so yeah. Thank you, Maria, for bringing that up. Telemedicine is another tool that we've been experimenting with, and that has pros and cons. But for an underserved area, and especially when you're talking about getting access to everyone, but especially immigrant populations, telemedicine, it can be another successful tool.
Okay. We have a question up here.
Hi, Natalie Keene with Justice and Aging. Thank you all for being here and for your comments. Curious if anyone has any thoughts on the impact of immigration policies on the direct care workforce. We know that a lot of direct care workers are immigrants themselves, and it's something that we were highlighting in the public charge conversation especially, but are there ways we can leverage that? I mean, I was thinking about the language access barriers. You know, the ideal is to have bilingual providers and so on. Any way we can bring that into the conversation?
Sure.
Well, unbeknownst to us, because like TPS, for instance, and I don't know if this is your question, but that TPS is a form of work permit that, and so we just asked people. So we didn't realize until this whole issue with TPS came up, but we're probably going to be hurt by this policy, in that about 100 of the 650 people that work for us are TPS that we didn't even know about. Right? There's another 10% of that group that is also DACA, and so I think that's a tremendous impact. And I think these are, and I have to say that some of our most loyal employees, in terms of loyal, I mean that are accountable, are patient-centered, are respectful, and work as a team, are those individuals. They get it. They know they've been through they've been there, and now want to give back to community. So, yeah.
Anybody else want to comment?
Yes, absolutely. That impacts, and we've seen it at our university level. We're an international community, so a big drop because of the immigration discussions and policies. A big drop of students from Mexico that some stay and work here in all areas. Then the other side, yes, in financial aid also being impacted for persons with different immigrant status. In all of our local community college, who has wonderful programs for medical office assistants, for phlebotomists, for lab technicians, respiratory techs, they've seen a drop because of the discussion on immigration policies. But again, what we've done as a community is gone out and outreached and make sure that our schools at the junior high and high school level understand and know of all of the different health professions possibilities. And so we're doing as a community a big push to make sure that we have a diverse population of healthcare providers, starting from the school-age kids.
Thank you.
That's great.
So I think we're about ready to wrap up.
Yeah. Any final questions for the group? Oh, look, a couple more. We might have time for. Yeah.
See, questions beget more questions.
Yes,
this is what I like.
Sorry, this may be a quick one. My name is Molly Schneider. I'm a fourth-year OBGYN resident, and we're here representing the American College of OBGYN. So this is obviously an important topic to us, as access and coverage for our patients is a huge deal. I'm fortunate enough to live in a state where we do have prenatal coverage for immigrants, although that coverage does only extend to 6 weeks. And so as a background, we've done a lot of research in maternal mortality recently and demonstrated that, number one, our 6-week postpartum period is sort of a made-up historical timeline, and we've demonstrated that half of maternal deaths are really within the first year, and only 22% in our state are within those first 6 weeks. So my question is, with that background, what are some of the timelines that you've heard thrown out for coverage based on some of our emerging data for extending coverage for maternal care?
If I may, thank you for bringing this up. And by the way, if you want to look at a new horizon to practice, you've got to consider that ill.
You're getting recruited via Skype.
You're being recruited via Skype. That's great.
Absolutely, every opportunity. But Texas has the same thing, only 4 to 6 weeks coverage and postpartum. And so our legislature meets every 2 years, and right now we've got proposals to extend it for a year. We've got to keep mom in care after pregnancy. And one of the things that concerns us, again, immigrant populations are impacted worse because they don't access because of their status in many times. But we're seeing high-risk pregnancies increase with preeclampsia, gestational diabetes, and in very young women. Right now, we've got a program with first-time moms, many of them recent immigrants, that average between 14 and 23 years of age, so very young moms, but coming out with high blood pressure during pregnancy. So moms are developing a high-risk pregnancy, and we want to make sure that we provide that care and extend it after for mom. But a question that we're also asking, how does a stressed pregnancy impact the growth and development of that baby? I mean, we've seen it with Zika now, that we know that a baby can be born healthy to a mom who was infected, and then within 2 years develop a congenital birth defect or other health issues. And so we're questioning what mom's got to stay in care, and if she's in care, then baby will also stay in care, and we want that. So in Texas, we're pushing that mom have a full year of emergency coverage after pregnancy, after delivery.
And let me just emphasize to continue the care throughout, because that second or third pregnancy is just the effects on the financial circumstances of that family and that child, that first child, are terrible. So
What's right? One more here.
Embry Howell of the Urban Institute. Hi, Maria. So there are two ways to approach it, as you pointed out at the beginning. And here at the Bipartisan Policy Center, I was hoping I might hear something about the other way, which would be reforming our immigration system so that more people are entitled to Medicaid, which is the broadest coverage we have. Is there anything on the horizon that might be suggesting that this might happen in the near future?
So I count myself as an eternal optimist because I've been working in immigration for about 20 years. So I always think there's a chance. I think that one of the reasons we agreed to do this panel between our health and our immigration projects is because of that linkage. Because whatever way we can do to help our policymakers understand that the immigration laws implicate not just the immigrants and the health of the immigrants, but our entire communities is another way of discussing why we need to change our immigration system in various ways. And the linkage there is, as we've heard people say, it's about the status, it's about healthcare providers and having the opportunity for immigrants to join our healthcare system. With some of the fastest growing occupations and needs we are going to have as a country are in the healthcare and health-related professions. All of these are, more and more apparent reasons why we have to sort of look at this holistically. And so it's not only about, as we've talked about here, the impact of health on the immigrants, but for a nation, we need to address all of these issues together. So I welcome any of my colleagues to talk about it, but that's one of the reasons we took on today.
Yeah, and I would just add that I think, we all view states as essentially the laboratories of democracy. And I think what we've heard from Duncan today, there are a lot of states who are taking steps in certain directions, whether it's waiving 5-year requirements to access health insurance coverage for lawfully permanent immigrants, whether it's looking at prenatal expansion of care for undocumented immigrants. And I think we need to learn from states, and I think we need to collect the data, and I think that's the most sort of powerful case that could be made, particularly at the federal level, when it's always going to be a little bit more political. So I think there are a lot of states that are thinking about these things, and I think that innovation needs to lead to better research and data and evidence, and then we need to communicate that information as well.
The other thing I would add is that the issues that our local leaders like Dr. Gonzalez have that are not necessarily conveyed all the time to the national level, and seeing and hearing about the issues that he is facing as a public health service provider in a border community, and the impacts of all of his federal partners, the federal laws, the issues, what's just happening down there right now, and how that impacts public health in his community. That's important to be heard at the national level as well.
Yes, thank you for saying that, because I don't know that there's a specific policy on the horizon. I know that in Laredo, our official stand from our mayor, council, and me from health is saying we need immigration reform, and part of that is understanding what we're seeing, this humanitarian crisis, not any other type of crisis. It's a humanitarian issue. And for us who live it on the ground, people need to understand that. So our stand here is that we need full, comprehensive immigration reform. What path that takes and how is come visit us, come see, come talk to us, because in many instances, our federal partners, talking about immigrants' health services, they don't know what's happening here until we call them and tell them. And so a part of the discussion is sitting down with locals, looking at what we have to do so that everyone that's in this country can access care.
I think that's probably a very good segue to close today's excellent event, and I want to thank all of the panelists and speakers. You all have been tremendous, and I'll let Teresa have the last word. But I think from my perspective, immigration policy may be a political issue. I think it's very important that we ensure immigrant health not be a political issue. And immigrant health needs to be thought about, and people need to care about it on both sides of the aisle. It doesn't matter what political affiliation you have. And I think immigrant health is also not just an issue for the state of California, the state of Texas, or the District of Columbia. These are issues being faced in every state of the country, whether you're in Kansas, whether you're in Minnesota, whether you're in Tennessee. And I think what we've heard from the panels today is that the health of immigrants, not only important for the immigrant themselves, but also for the wider community and the health and well-being and the vibrancy of those communities as well. And so I think immigrant health is an issue that is not just a niche issue, but I think one that all of us, stakeholders and policymakers, need to better understand and see how we can promote moving forward. So. And
I would just join on in thanking our panelists, Dr. Gonzalez for joining us by technology, Maria and Duncan for your expertise. I want to thank all of you in the audience. Again, I sort of made my closing statement earlier, but I would say from my perspective, we want to look at immigration reform from every angle and every potential rationale we can give to it. We at BPC believe that it is long overdue and it needs to be bipartisan as well. And so we hope that you will join us for a future event here. Thank you all for coming.
Thank you.